Welcome to Chapter 1 of Module 152. I know that 151 seemed like it drug on forever because I know you guys love to code, but we did learn a lot. I want to point out that I did submit a post for you guys that has all of your objectives. I want to remind you that if you look in your file, it's off to the left-hand side of your Edmodo over here, or your folders. You're going to have a syllabus that's going to tell you everything that we'll be doing in Module 152 broken down. It will have a week at a glance, and that's just a glance. It doesn't have everything on there, but if you're going to be reading chapter 17, it may be saying read chapter 17, and it may have the correct page numbers. But if you guys know that if you're going to read chapter 17, just look for chapter 17. But those are just little extra things. I'm also going to be putting up the whole PowerPoint presentation, not the one that I'm doing here, but the ones that come with the curriculum. So you guys will have those to be able to refer to. So as you are reading, if you want to read those and kind of mark in your book or however you think that may help you, those are new tools for you on Edmodo to be able to use. And I'm excited that we're leveling up our Edmodo and then I'm able to give you more and more, and I'm just going to get better and better and better at it. Okay, so without further ado, let's move into Chapter 1 of Module 152. And the name of this chapter is Reimbursement, HIPAA, and Compliance. So let me share my screen. Well, I thought this was all keyed up and ready to go. So the very first thing that we're going to be talking about is our objective number 1, which says distinguish among Medicare's Part A, B, C, and D. So you guys have it listed in your book a specific way, but I actually went out and did a little bit of research on my own to kind of give you maybe a little bit different perspective. I went and pulled information that you would get if you were interested in getting Medicare. Okay, so Part A is hospital coverage. When you apply for Medicare, you will automatically be enrolled in Part A. It covers hospital stays, hospice care, and some skilled nursing care that you may need after being hospitalized for a stroke, a broken hip, or other episodes that require rehabilitation in a nursing home or other facilities so you can get back on your feet. Most people don't have to pay a premium for Part A. You've already paid into the system in the form of Medicare tax deductions on your paycheck. That's why you have to be 65 to get Medicare Part A. However, Medicare Part A is not totally free. Medicare charges a hefty deductible each time you're admitted to the hospital. It changes every year, but for 2020, the deductible is $1,408. You can buy a supplemental or a Medigap policy to cover that deductible and some out-of-pocket costs for the other parts of Medicare. Medicare pays for virtually all hospital services for the first 60 days you're in the hospital. There are some exceptions. It won't pay for a private room. For example, if you're a U.S. citizen or permanent resident and have not worked long enough to qualify for Medicare, you may be able to buy into the program by paying a Part A premium. Okay, so let's talk about Part B, doctor and outpatient services. This part of Medicare covers doctor visits, lab tests, diagnostic screenings, medical equipment, ambulance transportation, and other outpatient services. Unlike Part A, Part B involves more costs, and you may want to defer signing up for it if you're still working and have insurance through your job or are covered by your spouse's health plan. But if you don't have other insurance and don't sign up for Part B, when you first enroll in Medicare, you'll likely have to pay a higher monthly premium for as long as you're in the program. The federal government sets the Part B monthly premium, which is $144.60 for 2020. It may be higher if your income is more than $87,000 a year. You'll also be subject to an annual deductible set at $198 for 2020. And you'll have to pay the 20% of the bills for doctor visits and other outpatient services. If you're collecting Social Security, the monthly premium will be deducted from your monthly benefit. Part C, Medicare Advantage. Medicare Advantage is the private health insurance alternative to the federally run original Medicare. Think of Advantage as a kind of nonstop shopping choice that combines various parts of Medicare into one plan. If you decide on a Medicare Advantage or MA plan, you'll still have to enroll in parts A and B and pay the B premium. Then in addition, you will have to choose a Medicare Advantage plan and sign up with your private insurer. And I'm going to let you guys read the rest of that. I want to give you an example of a Medicare Advantage program. It's called Vantage, and it was one of my favorite insurances to call because they were in Monroe, and I got to talk to the same person every time, and they were really, really clear and very cut and dry, and I never really had many questions after I spoke to a rep from their company. Most Medicare Advantage plans also fold in prescription drug coverage, but not all of these plans cover the same exact benefits, so make sure you read the plan descriptions carefully. Medicare Advantage plans generally are either health maintenance organizations, HMOs, or preferred provider organizations, PPOs. In HMOs, you typically choose a primary care doctor who will then direct your care, and usually you will have to give you a referral to see a specialist. PPOs have networks of doctors that you can see and facilities you can choose or you can use, often without the need of a referral. If you go to a provider who is not in the plan's network, you'll likely pay more. Guys, knowing about these insurances is so important. Make notes, and you have a project due on Thursday, or I assign it on Thursday, and I think it's due the same day. It's lab and homework. I'm sorry, I'm getting to that page so I can just give you a little more information. Yes, it's on Thursday, and it's your lab and homework, and you're going to be making a pamphlet outlining the most common third-party payers, HMO, PPO, Medicare, Medicaid. Start writing notes now. The medical coding and insurance portion, or the medical insurance portion of your NCCT, is actually more than the coding portion. So I want you to stop and really, really, really study, make notes of the differences between HMOs and PPOs, and really, really get to know, get to know these third-party payers. Part D is prescription drugs. This is the part of Medicare that pays for some of your prescription drugs. You buy a Part D plan through a private insurer. Each generally has premiums and other out-of-pocket costs, either flat copays for each medication or a percentage of the prescription drug cost. It also may have an annual deductible. So Part D equals drugs. I had a student about a year or so back, and she kept saying Part D was for dental. I always have to bring that up. I think of Lucretia whenever we go through this part for Part D Medicare. So let's watch this little video together.
FlexShares ETFs are built with advanced modeling to fill portfolio gaps and target specific goals, strengthening client confidence in you. Before investing, consider the fund's investment objectives, risks, charges, and expenses. Go to flexshares.com for a prospectus containing this information. Read it carefully.
Each day in the United States, 10,000 baby boomers, like Bob, celebrate their 65th birthday. And on that day, they get a special present from their Uncle Sam, Medicare eligibility. They'll join the roughly 49 million older Americans on Medicare and watch as their healthcare worries are whisked away. Or will they? Fidelity Investments estimates that the average couple retiring today at age 65 will spend a whopping $280,000 to cover healthcare and medical costs for the rest of their lives. So how is this possible? Let's go back to that 65th birthday. Bob just retired, and now he's ready to sign up for Medicare. He'll begin by choosing his coverage from Medicare's 4 parts. So if enrolling was multiple choice, he'd check all that apply. Check A to get hospital coverage, B to get regular medical coverage, D for prescription drug coverage, and Part C would actually be down here as all of the above. This part is known as Medicare Advantage. It typically includes everything here, but often adds a little extra. Now, Bob is in pretty good health, so Bob figures he'll enroll in Part A and Part B. Part A, as is usually the case, will have no premium, but it will come with a $1,340 deductible per benefit period, along with some limits on coverage. Part B, on the other hand, will have a monthly premium of $134, unless your income is over $85,000, in which case it will be higher. Part B will also have a deductible of $183 and then charge you 20% from there. Like all new enrollees, Bob's window to sign up is 3 months before and after the month of his 65th birthday. Late enrollment comes with a penalty, so Bob is sure to sign up in time and begins his epic retirement. He'll travel the world, learn to sail, and watch every sunset from a hammock. But a few months in, Bob goes for a checkup at the dentist and finds out that Medicare doesn't cover dental. And it's the same deal for Bob's eyes and ears. And if Bob needs care when traveling abroad, it's most likely coming out of his pocket. And as Bob gets older, those out-of-pocket costs can skyrocket. Need a tooth implant? That'll be $4,000. Hearing aid? $2,500. Then down the road comes a drug prescription. Bob never enrolled in Part D, so he has to either cover that cost completely or add Part D to his plan, which will now cost more since he's enrolling late. So now Bob's wondering, should I have just checked all of the above and gotten Medicare Advantage right off the bat? Let's run through a few scenarios. Say Bob was the same healthy 65-year-old, but he enrolled in Part D when he initially signed up. The plan he chooses has a $34 monthly premium, bringing Bob's total monthly premiums to $168. But now, Bob will only be forking over $5 or $10 for most prescriptions. But he still has a problem. He plans to travel. Medicare doesn't seem to have an option for overseas care. But this gap in coverage can be helped with the literally named Medigap. Medigap is supplemental insurance that covers some of the gaps in Medicare. Bob finds a Medigap policy that requires him to pay only 20% of emergency care abroad. The plan costs about $200, bringing his total monthly premiums to $368. But even with all that, Bob's still on the hook for vision and dental. That's where Part C comes in. Medicare Advantage usually incorporates all these parts, and you can also get vision and dental. But you cannot add on Medigap if you go this route. So Bob has a choice to make. He can combine Parts A, B, and D with a Medigap policy for $368 a month, or go for a Medicare Advantage plan and pay near a total of $170 per month. That may seem like a no-brainer, but that Advantage plan isn't quite the sweet deal it seems. Here, Bob won't be covered in Switzerland when he sprains his ankle hiking in the Alps, and that dental coverage is only good for one cleaning a year. It's a lot to think about, but luckily for Bob, he's healthy enough to cherry-pick his options. Let's say instead that Bob had a pre-existing condition. This won't hurt his eligibility for Medicare, but he is worried about covering the costs of treatment. If his best bet is to add a Medigap policy, Bob needs to jump on it right away. When you first enroll in Medicare, you have 6 months to add Medigap. After 6 months, you'll have to go through medical underwriting, meaning you could be charged more or denied coverage. When it comes to Medicare, planning is everything. But what if the really unpredictable happens? Say a few years into his retirement, Bob is diagnosed with cancer. Medicare will cover certain treatments like radiation or chemotherapy. If Bob needs to continue radiation treatment on an outpatient basis, coverage will come through Part B, meaning he'll pay 20% after that $183 deductible. So if the full treatment runs $20,000, Bob's on the hook for about $4,000. That amount could vary with the Advantage plan, and a Medigap policy may actually cover it. The last option Bob could turn to is government assistance. There are programs available that reduce Medicare-related costs. To qualify, though, your income must be below each program's limits. But if you do qualify, take advantage of it. Getting on Medicare doesn't necessarily put you on easy street, but it is still one of the best health insurers out there if you plan it right. As always, the earlier you do your homework, the quicker you can go out and play.
I hope that you found that interesting and very informative. Okay, so now we're going to move straight into HIPAA. Well, those of you that have been with me a little while probably are saying, I cannot believe she's mentioning HIPAA again. Well, yes, we mention HIPAA quite a bit, but we have to. So HIPAA stands for Health Insurance Portability and Accountability Act. It was established in 1996. Title Clue includes a section, Administrative Simplification requiring improved efficiency in health delivery by standardizing electronic data interchange and protection of confidentiality and security of health data through setting and enforcing standards. More specifically, HIPAA calls for standardizations of electronic patient health, administrative, and financial data, unique health identifiers for individuals, employers, health plans, and healthcare providers, security standards protecting the confidentiality and integrity of individually identifiable health information, past, present, or future. The bottom line, sweeping changes in most healthcare transaction administration information system. So that just simply means, and the reason that we're kind of talking about this in regards to Medicare and third-party payers is because the reimbursement factor in that, because you have to be HIPAA compliant. You have to sign these medical release forms. You have to get all these things done. And we learned so much of that in Module 151. And we're just reiterating again, when you're filing these claims, you need to be careful that you have all the documentation set up to be able to actually share this information with third-party payers, and that's part of HIPAA. You have to make sure that you're not sending data or personal health information, emailing it, things like that. That's the reason why it all kind of comes full circle in the curriculum. Okay, so let's talk about what is the Federal Registry. It's the official publication for all presidential documents, proposed rules, and notices. So the October edition of the Federal Register are of special interest to hospital facilities because the hospital updates are released in that edition. Okay, this is something you're going to have to remember. In October, the Federal Registry releases hospital facility updates. November and December contain major outpatient facility changes and physician fee schedule. Okay, so I am going to stop this share. Just bear with me because we're actually going to go to the Federal Registry so you can see what it looks like. Oh, I'm going to have to escape out of this, guys. Sorry. Let's see. Well, it's not wanting to let me out. Oh, there we go. Okay, so I went to federalregistry.gov is what I went to. And so this is what it looks like. And then it gives you different parts of, like you see, it's money, environment, world, health, and public welfare. I'm going to go and I find search and just put health care. And so when that comes up, look at, here's one, Medicare and Medicaid programs, patient protection and Affordable Care Act, interoperability, and different things like that. And that was on 5/1/2020, they updated something. So if you clicked on that, you could go in and read. Everything that's changed, any updates, specific things, background and summary provisions. In March 4th, 2019, Federal Register, we published the Medicare and Medicaid programs, Patient Protection and Affordable Care Act, interoperability and patient access for Medicare Advantage Organization and Medicare Managed Care Plans, state Medicaid agencies, CHIP agencies, and CHIP managed care entities, issuers of quality health plans of the federal. Anyway, so we could just keep on and on and on and read, but this is what the Federal Registry is, and this is what's online. So you can refer to that anytime to see what changes. There are, or if you're looking for something more specific, here's one on the healthcare reform. Importation of prescription drugs, Medicare program, and then you can look, this was 9/29/2020, 10/1/2020, 10/1/2020. So this is very, very up to date. So the Federal Registry is going to be a great place where you can look to see if anything has changed about a specific subject. Okay, so let's go back into our slides. Okay, so what are RBRVS's? Resource-based relative value scale. So on 2019, it's page 11, and on 2020, it's page 11 also. I've gotten used to just putting the two different editions on. So I'm just reading right underneath, physician payment reform was implemented to, and this is in your textbook, decrease Medicare expenditures, redistribute physicians' payments in more equitable. I'm going to skip that word. You see it right there. Equitability. I can't say it, guys. 3, to ensure quality health care at a reasonable rate. Okay, there's so much information here that this is what I would like for you to do. I would like for you to read and highlight key factors here. I could sit and read it to you, but it's not going to be the same as if you get into it and you read and highlight yourself. I do want you to take a close look at relative value unit. That is going to be on your NCCT. So that's on page 12, and it talks about work, overhead, malpractice, and practice expenses. You really, really, really need to pay close attention to that. Okay, let's talk about Medicare fraud and abuse. Medicare defines fraud as the intentional deception or misrepresentation that an individual knows to be false and does not believe to be true, and makes it knowing that the deception could result in some unauthorized benefits to himself or herself or to some other person. Some examples of fraud are altering medical records, upcoding, phantom billing, and double billing for the same service. Let's talk about beneficiary signatures. Most Medicare patients sign a standing approval, which is kept on file in the medical office. This allows Medicare claims to be filed automatically, which makes it easy for an unscrupulous person to submit charges for services that were never provided. This is where HIPAA comes in, keeping those signatures on file, keeping the information protected. So let's talk about fraud. Anyone who submits for Medicare services can be a violator. The physicians, the hospitals, the laboratories, billing services, and you. Coders must validate that the service was actually provided by consulting the medical record or the physician. If you didn't document it, it didn't happen. This is your motto as a coder. If it's not documented, it didn't happen, and until you get documentation, you cannot code it. Fraud can be billing for services not provided, misrepresenting diagnosis, kickbacks, unbundling services, falsifying medical necessity, routine waiver of copayment. So let's discuss how medical professionals, especially coders, should react if they suspect fraud. Okay, so I'm just going to tell you what I would do. I would gather my documentation, my proof. I would go to the office manager. I would present my documentation and my proof. And I would give her a solution of the things that needed to change and how it needs to be corrected. If They did not make the changes, and I knew that it was fraud and I could come up against scrutiny about it, I would give my notice and find another job personally. But I would also contact the OIG, the Office of Inspector Generals. Office of the Inspector General, OIG. The OIG is responsible for developing a work plan that outlines the ways in which the Medicare programs is monitored to identify fraud and abuse. So this is who would work on that and investigate that fraud. Complaints of fraud. Well, it's submitted orally or in writing to MACs, which is our managed. What are MACs? My mind just went blank. All right, let's just go with MACs or OIG. Allegations made by anyone against anyone. Allegation followed up by MACs or other OIG. Abuse generally involves impropriety, lack of medical necessity for services reported. Review takes place after the claims are submitted and may go back and do historic review of the claims. Abuse reviews involve checking the propriety or medical necessity of services that are billed. These reviews generally occur after claims processing activity. Fraud reviews may determine, for example, whether or not billed services were actually furnished. Kickbacks. Okay, this is so important. We have to know our laws. Anti-kickback laws, we have Stark Law, False Claims Act, Truth in Lending Act. We've gone over it before, but guys, this is a place where we're going to look at the Stark Law, the anti-kickback law right now. Kickbacks are a bribe or rebate for referring patient for any services covered by Medicare. Any personal gain is a kickback. It's a felony. You can get a fine, go to jail, or both. So we're going to watch a little video on what is the anti-kickback law.
Latham's word of the day from the Book of Jargon, Healthcare and Life Sciences, is anti-kickback statute. The federal anti-kickback statute is a federal law that prohibits the offer, payment, solicitation, or receipt of remuneration that is intended to induce the referral, recommendation, or arranging for items or services paid for by federal healthcare programs. The anti-kickback statute defines remuneration very broadly to include almost anything of value. This means things like meals, entertainment, business courtesies, client gifts, and even discounts on financial arrangements between parties are included. One of the reasons that our clients are so concerned with anti-kickback statute compliance is that the statute makes illegal business practices that are ordinary in any other industry. Anti-kickback statute.
Okay. I'm sorry, guys. I'm trying to get out of there. Okay, so I do want to say that I went back and found out what MAC stand for. MACs are. They're Medicare Administrative Contractors, MACs. Let me tell you why I got off. It's because I was thinking of MCOs, which is a managed care organization. And so my mind got all tangled up. So an MAC is a Medicare Administrative Contractors, and that's on page 3 of your step-by-step. So protect yourself. Use your common sense. Submit only truthful and accurate claims. If you are unsure about charges, check with your physician or your supervisor. Okay, what's going on? Well, I have one more slide and it wouldn't let me give it to you. So this is where I'm going to be. Okay, so your last objective, we went through objective, which is found at the beginning of your chapter 1 through 5. Your last objective will be covered tomorrow through your project. And that is actually going to be identify the major components of managed health care. So that's going to be your HMOs, your PPOs, your Medicare, Medicaid, TRICARE, CHAMP VA. It's going to be those things. So I want you to keep in mind the things that you're going to want to put in your informational pamphlet. I actually did load 2 videos of a couple of different options of how you may want to do that. But yeah, that is our lecture for chapter 1. I hope you guys learned a lot. I'm sorry for my little snafu on my MACs and couldn't remember what it was. Anyway, if I can do anything to help you guys, let me know. Bye-bye.